Hello and welcome everyone to our multi-state collaboration. My name is Jill Bullock. I'm the Flex Coordinator for the Arizona Center for Rural Health, and I'd like to welcome you all to our webinar, Treating Pain in Rural Healthcare. And again, this is a webinar that's part of our multi-state collaboration with Utah and Washington and North or South Dakota and Oregon and Idaho. And so we're continuing our multi-state collaboration with you all and hope that you enjoy today's webinar.
Okay. Thank you, Jill. Good morning, everyone. My name is Rocio Torres, and I am with the Overdose Data to Action States, OD2AS, at the Arizona Center for Rural Health. It is my pleasure to welcome everyone to this webinar and introduce our speaker, Dr. Zhanette Coffee. Dr. Coffee is a postdoctoral research associate engaged in a synergetic training environment between the University of Arizona's College of Nursing and Health Sciences Comprehensive Center for Pain and Addiction. She's also a member of the University of Arizona College of Medicine's Harm Reduction Research Lab. As a dual certified nurse, Dr. Coffee brings expertise in addiction, chronic pain, mental health, and integrative health approaches. Dr. Zhanette earned her PhD in nursing from the University of Arizona in 2023. Her research focuses on advancing addiction and pain science by developing innovative whole-person care approaches that address the needs of both patients and providers. Through multi-level solutions, she aims to improve clinical workflows, enhance provider support, and optimize patient outcomes. With over a decade of experience, Dr. Coffee has served in diverse roles, including addiction and pain practitioner supervisor in detox, residential, and outpatient setting, as well as clinical researcher, nursing faculty, public health nurse, and police officer. A recipient of numerous honors, Dr. Coffee is actively involved in organizations such as the American Association of Nurse Practitioners. She also serves as secretary of the Jonas Scholar Alumni Council. Dr. Coffee is deeply committed to advancing whole-person, evidence-based care for pain and addiction. Thank you, Dr. Coffee, and the floor is yours.
Thank you so much, Rocio, and thank you, Jill. Hello, everyone. Good afternoon. And that was such a wonderful introduction. I appreciate that. My hope for you today is that we will hopefully discuss some pain approaches to add some management tools to your tool belt in order to effectively manage pain patients. So let's get started here. So we respectfully acknowledge that the University of Arizona is on the land and territories of Indigenous people. Today, Arizona is home of 22 federally recognized tribes, with Tucson being home of the O'odham and the Yaqui. Committed to diversity and inclusion, the university strives to build sustainable relationships with sovereign Native nations and Indigenous communities through education offerings, partnerships, and community service. We conduct this land acknowledgement to really speak and acknowledge history, remember that Indigenous people are strong, and to be an ally. So the mission of the University of Arizona, Arizona Center for Rural Health is to improve the health and wellness of Arizona's rural and underserved populations. And the mission for the Comprehensive Center for Pain and Addiction is to advance science to provide students, educators, professionals, leaders, and communities with evidence-based insights, therapies, and resources. I do have some disclosures and disclaimers. I am being paid to conduct this webinar today, but I don't have any other financial disclosures to report. A disclaimer: the material presented here was supported by the grant number listed on the slide, funded by the Centers for Disease Control and Prevention. Its contents are solely the responsibility of the authors and do not necessarily represent the official views of the Center of Disease Control and Prevention or the Department of Health and Human Services. This webinar series is made possible through the funding provided by the Health Resources and Services Administration. and the Federal Office of Rural Health Policy Medicare Rural Hospital Flexibility Program. So we do want to pause and recognize all the people who have lost their lives due to accidental poisoning, substance use, misuse, and addiction, and their families and communities. In 2023, about 105,000 people died from drug overdose in the US, and the rates nearly quadrupled between the time period of 2003 and 2022. And we are just starting to see these rates decline, thankfully. We continue to work to develop and implement evidence-based solutions for current and future generations. We recognize more than 29 million adults who perceive that they ever had a substance use problem. About 72% consider themselves in recovery or recovered. So prevention, harm reduction, treatment, and recovery, they do work. Here are our learning objectives for this webinar. The first is to analyze opioids and complementary treatments for pain. The second is to articulate strategies to offer whole person pain treatments. And the third is to connect pain treatments to safe use of opioids, quality improvement measure. So let's discuss a little bit about the background and relevance. So pain is defined as an unpleasant sensory or emotional experience associated with actual or potential tissue damage. There are 3 different types of pain based on duration. The first is acute, which is less than 1 month. The second is subacute, which is between 1 and 3 months. And then chronic pain, which is a duration greater than 3 months. Pain can also be classified as nociceptive tissue injury related pain, which also includes musculoskeletal pain. There's neuropathic pain, inflammatory pain that really categorizes some autoimmune disorders, as well as functional centralized pain. And pain is one of the most common reasons adults seek medical care in the US, and about 1 in 5 or 20% of adults have chronic pain, and 1 in 14 adults experience high impact chronic pain. And that's defined as having pain on most days or every day during the past 3 months that limit life and work activities. The economic costs of chronic pain were estimated up to about $635 billion in annual direct medical costs, loss of productivity, and disability. Pain is a complex phenomenon influenced by multiple factors, including biological, psychological, social, and economic factors. Therefore, prevention, assessment, and treatment of pain is a persistent challenge for clinicians. Pain might go unrecognized, and some patients, members of marginalized racial and ethnic groups, women, older patients, patients with cognitive impairment, also patients with mental or substance use disorders, sickle cell disease, cancer-related pain, as well as patients with end of life, can be at risk for inadequate pain treatment. So it's important to view pain, particularly chronic pain, through the biopsychosocial economic lens that you can see on the slide there, identifying potential influencing factors to the pain experience. CDC updated their practice guidelines for prescribing opiates for pain in 2022, and it provides 12 evidence-based recommendations in 4 practice areas. It's for people who are 18 years and older. It does not apply for pain management related to active cancer treatment, palliative care, or end-of-life care. They do not replace clinical judgment or shared decision-making processes with patients and their families. It's intended to be flexible to enable person-centered decision-making, taking into account the patient's expected health outcomes and well-being. The recommendations really aim to improve the communication between clinicians and patients about the benefits and risk of prescription opioids and other pain treatment strategies to improve the safety and effectiveness of pain treatment, improve pain function and quality of life for patients with pain, and reduce the risk associated with opiate pain treatment, including opioid use disorder, overdose, and death. So the first learning objective here is to analyze opioids and complementary treatments for pain. So let's discuss a little bit about opiate risk. So according to CDC guidelines, opioids should not be considered first line or routine therapy for subacute or chronic pain. Prescription opiates do carry risks such as withdrawal, overdose, opioid use disorder. You can also develop tolerance and physical dependence, especially with chronic use over time. Increased sensitivity to pain. We actually call this hyperalgesia, where the pain can actually be spread out and more intensified with chronic use of opioids. Mixing or co-prescribing drugs, so opioids and alcohol, cocaine, or benzodiazepines, that co-prescribing can actually decrease the respiratory drive for patients, increasing the risk for overdose. Drug potency, so we're currently experiencing a fentanyl crisis with non-regulated drugs. Low tolerance if there's a period of abstinence due to incarceration, hospitalization, or inpatient treatment. And overdosing or using alone, so really no one to call 911 or to administer naloxone if an overdose occurs. A weak immune system or illness with long-term opiate use. And improper storage of opiates may harm children. Opioid use disorder has a disproportionate effect on rural communities with respect to prescribing, overdose, and mortality. People in rural communities may be at higher risk for chronic pain because they may rely on manufacturing or service jobs, including the military, increasing their chances of injury, opiate exposure, and fatal overdose. So here are some non-opiate treatments for pain management that you can consider in your practice or in the rural healthcare area. Consider these non-opiate alternatives as a first-line therapy to treat chronic pain under some conditions. According to the CDC guidelines, non-pharmacological approaches are first line. It really supports the patient as an active participant in their pain management. It targets holistic whole person biopsychosocial aspects to the patient, can boost pain self-efficacy, can improve pain perception, can foster a sense of control, and they have the least side effects out of the three that you see on the slide there. So I'm not going to go over, just for the sake of time, all of them, but there's cognitive behavioral therapy, there's exercise, physical therapy, and mind-body therapies, things like acupuncture, yoga, tai chi, mindfulness-based and stress reduction techniques. There are non-invasive devices. I do want to emphasize that insurance coverage may vary for these devices, but some of those non-invasive devices are like a TENS unit, a NextWave or an H-Wave. There's also a remote electrical neuromodulation for migraines. So the next there that you see is non-opioid medications. And there's several listed there. And for the sake of time, I won't go over each of those. But I do want to emphasize, let's not forget about topical and oral NSAIDs. Or naproxen, and even a diflucanac gel, like a topical, as well as Celebrex. You know, those can go a long way to help treat pain. And also local anesthetics, things like lidocaine patches. When I was practicing as a nurse practitioner, I noticed that those were actually underutilized a lot, and they can be very effective for pain. Also for individuals with diabetic neuropathy or peripheral neuropathy, duloxetine and pregabalin are FDA approved for treatment of that pain. And patients with co-occurring pain and depression might be especially likely to benefit from antidepressants. And it's important that we also look at interventional treatments. Those are more invasive, of course, and can have other complications and higher risk for side effects, but some individuals are, they need them and they're appropriate in some cases for patients. And it's important as we look at these different approaches and options for pain management to articulate pain classification for choosing effective treatment strategies. So think about opioid versus non-opioid, physical therapy, psychological interventions, because multimodal pain management is often required, combining medications, integrative therapies, and lifestyle modifications. Chronic pain conditions do require that biopsychosocial approach in integrating physical, psychological, and social factors into their treatment. So the second learning objective here is to articulate strategies to offer whole person pain treatments. And as we discuss whole person pain treatments, it's important to emphasize the need to screen patients for opiate misuse or opiate use disorder when managing patients with pain, especially if the patient is newly under your care and already receiving opiate therapy for pain. It's important to talk about the risk associated with opioids, providing education on overdose recognition, naloxone, I can't say that enough, Narcan for patients with opiate use, offering medications to manage withdrawal symptoms, treat opiate use disorder with medications like buprenorphine that are highly effective. And I want to highlight for buprenorphine, in May of 2019, the U.S. Department of Health and Human Services and the Pain Management Best Practices Interagency Task Force actually encourages primary use of buprenorphine when opiates are appropriate for chronic pain due to the reduced potential for respiratory depression. And it's important to connect with pharmacies to ensure that medications are actually available. And then as we screen patients for either opiate misuse or opiate use disorder, I like to highlight the 4 C's of addiction, which is compulsion, craving, consequences, which is continued use despite harm, and control or loss of control. And there is a single screening question that can be used, and the literature actually shows 100% sensitivity for primary care. The example of that is, how many times in the past year have you used an illegal drug or used a prescription medication for non-medical reasons? And that can be just a quick question that can really gain some insight on any opiate misuse or opiate use disorder. And then there are formal tools that we can use, things like the DSM-5 criteria for opioid use disorder that really categorizes mild, moderate, or severe opioid use disorder. There's also assessments for predicting risk of opiate misuse, like the opioid risk tool, or the ORT, as well as the CALM scale, which is a current opioid misuse measure. And then, of course, we want to familiarize ourselves with the clinical opioid withdrawal scale for any active opioid withdrawal, and that's called the CAHs scale. So strategies to offer whole person pain treatments. So modern medicine view of chronic pain really views the patient as a passive recipient compared to a whole person health, which empowers patients to sustain their well-being, supporting patients to be active participants in their pain management. The current methods to evaluate chronic pain primarily focus on the physical components of pain and often neglect the psychological or the social factors. Whole person pain treatment integrates biological, psychological, social, and lifestyle factors to improve pain management and overall well-being. Whole person pain management moves beyond just medications by integrating mind-body, movement, nutrition, behavioral, and complementary therapies tailored to individual needs. By offering multimodal, patient-centered approaches, healthcare providers can improve pain outcomes, enhance quality of life, and reduce reliance on opioids. There's some key topics here that I just want to share with you. So things to consider are non-opioid medications for pain relief, mind-body therapies for pain perception and regulation, movement-based therapies for physical and functional improvement, so nutritional and anti-inflammatory approaches, behavioral health and social support interventions, sleep and nervous system regulation, as well as environmental and lifestyle modifications. Something that I'm actually going to share in the chat is a personalized pain coping toolbox that I actually use as a nurse practitioner when treating patients with chronic pain. And it actually is a whole person approach that they can personalize. I'm hoping that that will share with you. Just make sure in the chat. And it's something that they can personalize. And I used it as a nurse practitioner, especially with pain flares and exacerbation of pain. But they can look at the physical things that they can do physically to help with their pain, the emotional and feelings that surround with the pain experience, cognitive, the way we think about pain or perception about pain, social, maybe other people that can help support the individual, environmental and their surroundings, and then spiritual, philosophy of life and purpose. So some policy changes. So as of January 2023, a notice of intent to prescribe buprenorphine for the purpose of opioid use disorder treatment, or what's called the X waiver, is no longer required. All practitioners who have a current DEA registration that includes Schedule III authority can now prescribe buprenorphine for opioid use disorder in their practice if permitted by a state law. However, there is training that is required. That specific training, so there's a new federal MAT Act that was passed as part of the Consolidated Appropriations Act of 2023. It includes training on opioid controlled substances, pain management, and addiction education. And this primarily is for practitioners renewing or newly applying for a registration for the DEA to prescribe any controlled medications. And there's several states, including Arizona, which require licensed practitioners to engage in this training and education. And some states, even California, which will hopefully be adopted by all states, beginning January 1st, 2025, all licensee with a furnishing license are required to discuss with documented conversation the risk associated with opioid use and addiction with patients, regardless of their age, prior to issuing or dispensing opioids. The provider and the patient discussion must address the following: the risk of addiction and overdose associated with the use of opioids, the increased risk of addiction to an opioid for an individual who is suffering from both mental health and substance use disorders, and the danger of taking opioid with benzodiazepine or even alcohol and other central nervous system depressants. So the third learning objective here is to connect pain treatments to safe use of opioids and quality improvement measures. So safe use of opioids. In 2020, the Centers for Medicare and Medicaid Services, so CMS, created a roadmap that basically is a strategy to fight the opioid crisis. As one of the largest payers of healthcare services, CMS has a vital role in addressing the opioid epidemic and is focused on three key areas: prevention, which is really managing pain using safe and effective range of treatment options and rely less on prescription opioids; treatment, which is really to expand access to treatment for opioid use disorder; and data, using data to target prevention and treatment efforts to identify fraud and abuse. So the patient safety and safe use opioids annual CMS measure, or the ECQM, is for critical access hospitals. They're required to report this measure annually on safe use of opioids. And the CMS basically uses this to assess safe prescribing practices related to opioids and benzodiazepine at hospital discharge. It aims to reduce the risk of overdose, respiratory depression, and other adverse effects associated with concurrent opioid and benzodiazepine use, supports opioid stewardship efforts to align with CDC and FDA recommendations, and encourages safe prescribing practices to minimize the risk of opioid use disorder dependence and overdose deaths. Some of the implications for hospitals and providers: so hospitals must track and report this measure as part of the CMS quality reporting requirements. And providers should implement opioid stewardship strategies, which include reviewing medication lists before discharge, really utilizing the prescription drug monitoring programs to track opioid and benzodiazepine prescriptions, and then educating patients about the risk, encouraging alternative treatments like non-opioid treatment management, as discussed earlier. So there's some patient counseling checklists, really the risk of respiratory depression and overdose for the patients that are prescribed opiates at discharge and benzodiazepines, the importance of gradual benzodiazepine tapering if necessary and the counseling around that, safe opioid storage and disposal, and of course naloxone for co-prescribing for high-risk patients. Early detection of high-risk patients can prevent unnecessary concurrent prescribing, and provider education, even EHR decision support tools, can improve adherence to best practices, and opioid-sparing pain management and non-benzodiazepine alternatives should be prioritized. A multidisciplinary collaboration is essential for long-term success in reducing concurrent opioid and benzodiazepine prescribing. I did create a very quick acronym that I'm hoping will be helpful, and it's called PACE. So pace yourself as you discharge patients. And the P is really patient-centered education, whole person health, the risk and benefit of pain management options, alternatives, that's the A, whole person approaches to be considered. The C is check, confirm, and counsel, especially the prescription drug monitoring program. And don't forget Narcan. as well as evaluate the plan and use shared decision-making with the patient to adjust as needed. And I'm going to go ahead and put that quick acronym that I quickly developed for you guys to remember in the chat there. And so we're going to move on to our case study and group discussion. And here is an outline of the group discussion here, and I'll show a video shortly of the case study, but from your personal perspective, recommend a discharge plan for the patient in the video. So really look at clinical, administration, quality improvement for the patient discharge plan, and identify one person from your team. You will be separated into some breakout groups here to share your group's thoughts with everyone. The team lead will share discharge plan with everyone and answer the following questions. What, if any, was challenging about the case? And what is one thing that you learned? And of course, really try to integrate some of the information that I discussed today, especially about the whole person care model. So I'm going to go ahead and play the video. I'm going to stop sharing my screen really quick. And I'm going to pull up the video for everyone. Bear with me. Share my screen. Are you able to see my screen okay? Yes?
Yes.
Okay,
Yes.
thank you.
Can you make, yeah, you can make it bigger.
Absolutely. I'm going to make it bigger here. There we go. And play it. And it does take a moment to hear the sound.
You got the door? Ready for a report on room 346?
Yes, I am.
Okay, so we have an Yvette Ogum. She is a 34-year-old female brought into ambulance last night at 1800 for a heroin overdose. She was given 2 doses of naloxone, 2 milligrams each dose. She vomited twice following the naloxone. Following stabilization in the ER, she's brought to our floor for monitoring. Patient is allergic to aspirin and has a history of back surgery in 2012. She has depression and drug abuse. Patient has been admitted twice before for heroin overdose and has been sent to rehab 3 times in the last 3 years. I'm guessing she became addicted to the pain medication after her back surgery and switched over to heroin because it was cheaper and easier to get. She did tell me that she's currently going through a divorce with her husband and that she has a bad relationship with her 2 kids. No surprise there. Patient is a hard stick and has a 22 gauge in her right forearm. Labs pending for ETOH, urine toxicology, CBC, CMP, magnesium, and phosphorus. In terms of assessment, she is alert and oriented ×3, lung sounds clear, pulse is strong, abdomen tender. She has track marks all over her extremities, no sign of cellulitis or abscesses yet, but keep watch of her left forearm. We have her on 400 milligrams ibuprofen every 6 hours for her back pain. Next dose is at 8 a.m. She's been ringing her call bell every hour. She is super anxious. She's really high maintenance. So best just to avoid her. She's a drug seeker. She will eat up all your time. Good luck with her.
I'm feeling very concerned about the direction we're going here. I know you're trying to give me a heads up on the situation, but labeling the patient can be unproductive. My experience has been that most often these patients are under-medicated. What was our most recent CAHs score?
Her most recent CAHs score was 14.
And how did she sleep last night?
With the amount of time she was using her call bell, I'm pretty sure she didn't get any sleep last night. I gotta get out of here. Good luck with her.
Hello, I'm Sharon. I'm going to be your nurse for today. What would you like to be called?
Look, I've been in severe pain all night. All they gave me was Motrin. Motrin's fine for bee stings, but it's not going to do anything to help the pain. It's going to drive me through that wall.
I'm sorry you feel bad. I'm here to help you. Can you please rate your pain on a scale of 1 to 10?
It feels like a Mack truck ran over my back, backed up and ran back over it again. A 25. Some morphine.
Okay, I'll see what I can do. But first, I have to do an assessment. I'm going to ask you some questions. Are you feeling any other symptoms?
You mean besides being annoyed by these twits, being ignored when I call for help, and being treated like a leper?
I'm sorry you feel this way, like you've been ignored. It seems like you had a rough night and are very uncomfortable. I'm gonna call the doctor to see if I can get some more pain medicine for your withdrawal symptoms. But first, I'm gonna complete an assessment on you, okay?
Whatever.
Do you have any tremors? Okay, I'm gonna check your heart rate. I'm gonna look into your eyes. Thank you. How many times have you vomited?
3 times since I got here.
Is it still clear or liquid coming up?
Yeah.
Have you had any diarrhea?
Yeah, and soon all my insides will either be out or puked up. Have some oxy.
Okay, I'm gonna call the doctor for you to get some more pain medicine, okay? I have seen that you're sweated through your gown. I'm gonna get you a new gown, some cool compress, and I have some nausea medication for you. Does that sound like a plan?
Whatever. I'll believe it when I see it.
Okay, I'll be right back with that, okay?
Hello, this is Dr. Lopez. How may I help you?
Dr. Lopez, this is Sharon Fairweather calling from Montgomery Hospital about your patient, Ms. Yvette Ogam, in room 346.
Oh, yes, I remember her. What is happening with her now?
She was admitted for heroin overdose yesterday. Her CAHs score is a 35. She has a history of depression and back pain following surgery 5 years ago. She appears to be in a lot of pain and is anxious and vomiting.
What's her vital signs?
Blood pressure 150/85, heart rate 122, respirations 22, temperature 98.6, pulse ox 100% on room air. She's due for her ibuprofen, but that does not seem to cover her back pain. I am worried that she's withdrawing from heroin. I would like to have an order for anti-anxiety medication and something besides the ibuprofen for her pain.
Any allergies?
Only to aspirin.
Okay, give her,
Your CAHs score is now a 10. How are you feeling about your pain now?
I can manage. You know, you're the only one that's treated me like a human being since I got here.
You know, heroin withdrawal is no walk in a park. I've seen you've been through detox several times. We're gonna help you get help when you leave here.
I can't keep doing this to my kids. They need me.
I am here for you, to support you. We're gonna get you help, and we're gonna look at all the solutions that are possible. You are not alone. We're all working together for you to feel better.
And stop sharing my screen there. And should I pass it along where we go into breakout sessions now?
Dr. Coffee, we don't have enough people for the breakout rooms, so
Oh,
we're
yes.
gonna do the
Okay.
activity in the main room. Thank
Perfect.
you.
Yes, thank you for the reminder. I appreciate that. Okay, so as we just listened to that great video and case study here of the patient and some of the questions that we originally, maybe I should pull up the questions. That would probably be really helpful. Let's bring up those questions again. Sorry, I'm just gonna share my screen and remind you all of the questions. Okay, can you see that okay? Yes?
Yep.
Okay, wonderful, thank you. Okay, so make sure that you consider a discharge plan for clinical administration and quality improvement. And then if someone's willing to share, we don't have groups now. So if someone wants to share a potential discharge plan or your thoughts about the case, I'm happy to have this an open discussion and talk through and even share some of my insights on clinical considerations, administrative, and quality improvement. Would anyone like to share? Don't be shy. Or if anyone wants to share what was challenging about the case, if anything that you noticed.
Dr. Coffee, I can start. This is Andy.
Sure.
So I'm not a clinician. However, I would think setting her up with some type of rehab afterwards would be pretty wise, and making sure that she has resources available when she leaves the hospital.
Absolutely, absolutely. So we want to think about the high risk, right? Really trying to get this patient stabilized. It looks like her CAL scale went down, but she's absolutely going to need some resources. So great point there. Absolutely.
One other point I make is just the feelings on it about how the second nurse really took the compassion towards the care, and the patient noticed that, and the first nurse was just so judgmental right off the bat. And I know that our brains go right to judgmental in a lot of instances. However, I really commend that second nurse for how she treated the case.
Absolutely, Andy, great point. And as you mentioned, yes, we can easily go there for judgmental, but it's important to reel that back and have a non-judgmental approach to care, really being humanistic and holistic in our approaches, because that's the harmony of what we do is provide care, right? That patient needs assistance. The patient's in active withdrawal. Really mitigating stigmatizing language. I think the second nurse did a really great job to address that. And as you mentioned, Andy, really addressing the whole person, right? Talking to her, that shared decision making with the patient, and to really get her stabilized, and then even discussing some resources for discharge. But great point, absolutely.
I have a question.
Sure.
And I don't know, I'm not clinical either. If you could go over the CAHs score, or what, I don't know if everybody knows what it is. I don't, but
Sure, yes. So the clinical opiate withdrawal scale is a evidence-based scale that can be used to assess active withdrawal. And there's different portions of the CAHs scale. And I'll actually tell you some of them verbatim, but there's categories to really assess pulse rate, sweating, restlessness, pupil eye size, even bone and joint aches, GI upset, tremors, yawning, anxiety, irritability, and goose bumps on the skin that you can actually verbally, objectively assess on the patient. And these are all active signs of withdrawal. And there's a point scale to basically on each of those sections to write points of some of those measures that they are exhibiting or showing. And the scoring is basically a score of 5 to 12 is mild, 13 to 24 is moderate, and then 25 to 36 is moderately severe, and then more than 36 is severe withdrawal. Does anyone remember what her score was?
35, right?
35, yes, it was 35. That is severe withdrawal. She needs medical management. She needs some even medications to help with some of those withdrawal symptoms. And even some of the holistic things like changing her gown can go a long way with patients. Hydration, especially as they're going through withdrawal, and things like, the GI upset, diarrhea, is very prevalent with patient, even nausea and vomiting in active heroin withdrawal. So really treating that from the clinical perspective is key. So I hope that answers your question on the CAHs score.
Yes, and I was going to ask you if that wonderful, compassionate nurse helped lower those scores, but you said changing the gowns.
Yes.
Yeah, that, versus what the other nurse who handed off.
Yes. Yes, and I'm not sure if you remember the follow-up score when the patient seemed much more coherent and a little bit of out of withdrawal. The CAHs score was 10. So it significantly reduced and went into mild according to the CAHs scale. So great
I have a
point.
comment to Dr. Coffee. I think using the coping toolbox that you put in the chat, the personalized pain, and also the strategies to offer whole person pain treatments.
Yeah.
I think that my impression was that the care team didn't include the patient as part of the team. So I would say that that's number one. And also the intersections between the physical, emotional, cognitive, social, environmental, and spiritual. I didn't have the impression that those components were touched in the approach that the care team used for this patient. So that would be one of the options that they can use for this search plan. I'm not a clinical or administrative or quality improvement, but I can give my feedback on my public health perspective.
Absolutely. Great points, Rocio. Absolutely. And I can add to that, especially for the administration. So really addressing the social determinants of health barriers, maybe like social work for housing, transportation assistance for appointments, follow up with continuity of care. Like Andy mentioned earlier, really having some discharge planning for either a primary care appointment, recovery treatment programs, even mental health providers, and even pharmacy coordination, right? To make sure that the patient receives their medications for opioid use disorder as well as Narcan, which is very important.
We do have a hand raised, Amy.
Oh, sure.
Yeah, I was just gonna make a comment for that. The first nurse, I think that for a lot of the acute care units, they're just woefully underprepared to take care of these types of patients just because they're not educated. And I find that a lot of times they fill out these scores, not understanding that there's interventions to be made. The second nurse certainly understood that. And so I think that that's a big part of this because they didn't go into acute care nursing to take care of, you'll hear that, to take care of these types of patients. But the reality is these types of patients are in here all the time now. So that is what they need, more education on how to take care for them. So I think that's a big component of this is just more education. What do these scores mean, and how are they supposed to advocate for them? So.
Right. Great point, Amy. I agree with you. I think we can easily get into check the box kind of modality where we're, trying to, okay, I got the score. This is the patient. This is what I'm doing. I'm doing a handoff. I first worked in ICU as a registered nurse, and it's fast paced, right? You're very busy, and we can easily go into checking the box, but there's still a patient behind that, right? And so we really want to make sure that we're really treating the patient, really assessing all aspects of care, not just, okay, I have this, CAHs scale and this is what it is right now, but really getting to the patient's level, really discussing, how you can improve the quality of life and the well-being for that patient, especially on discharge. And part of that, as you mentioned, Amy, is provider and staff training. Really training on effective care, especially stigmatizing language that can really impact that patient trust, is so essential. And compassionate care and empathy and support really matter and can go a long way and improve the outcomes for patients. Any other comments?
We have a couple pharmacists on the call, and I'm just
Yeah.
wondering, if they want to chime in at all in their roles. No pressure.
I can comment. This is Mike. I'm in Oregon,
Hi, Mike.
and I'm the manager or director of the pharmacy in a critical access hospital. And yeah, we definitely are seeing an uptick in the number of patients
Mhm.
that need assistance, and we're just getting to the point where we're building that CAHs scoring into the nurse assessment. And
Good.
so we got a lot of education to do that. And we see it a lot in the birthing center, where, needing to do some maintenance therapy and trying to verify the doses that they're on as an outpatient when they come inside is a lot of times pretty hard
Mhm.
to get a hold of the treatment centers,
Mhm.
things like that. But we do have a pretty good interface with our ED and have done some pretty good education for providers in the ED and using that using the new rules where you don't need the X waiver. And so ED providers have been actively engaging patients, and we've educated the nursing staff in the ED about that.
Oh, great. And are
So-
you seeing an uptake of providers since I'm just very curious, since the removal of the X waiver, have you seen an uptake of providers that are willing to prescribe medications for opioid use disorder like buprenorphine?
I'm not sure. I don't see a lot of outpatient prescriptions, so I don't know how that is spread amongst, the primary care providers. I know that the ED docs, all our ED docs have done that, and have, been able to do that and try to interface them with the treatment center, as they come out of the ED if needed.
Well, thank you, Mike. Thank you for those insights.
I have a comment, Joyce. I'm also non-clinical, but I found, and I'm glad it was brought up about the first nurse talking to the second nurse. And I hear, where in hospitals they do rounding. And so would this have been a good case where you would do the rounding so that it was an unfortunate handoff to that nurse, and she was very patient, but it seemed to me that a case like this, especially with the history of coming back in and all that, that more care should have been given to what this patient's been through and all of that, and that you understand, and the points are being brought up, you understand all the drugs that she was on and all that. So I just thought that, you hear about rounding, and I thought, well, that'd be a good case for that. Thank you.
Well, Joyce, that's an excellent point, and I would be surprised if you're not clinical because you sound very clinical with that.
Clinical at all. And I never want to be.
But you are speaking of quality improvement, just as you mentioned, right? If this is a person that has been, at the hospital before, there should be a multidisciplinary kind of approach with this patient to really make sure that they're mitigating risk for return to use or even overdose as the patient gets discharged. But that rounding is so important. So everyone's on the same page to give the best treatment for that patient as they have access to that patient, because it could be life-saving. So you're absolutely right, Joyce.
Yeah, and especially because having the pharmacists on this call, which I think is just excellent, they're key. They're key. So
Absolutely.
Thank you.
Thank you, Joyce. Any other comments? Okay. Should I proceed, Rocio?
Yes, yeah, go ahead.
Okay. Wonderful. Well, thank you everyone for that engaging discussion. I hope that you found the video informative and learned something from it. Add some more tools under your management tool belt, I like to say. Well, let's go to the next slides here. Remember, we have the ability to meet people where they are. offering them compassion, understanding as support, as we just discussed about the video. But our role goes beyond just meeting them in their current situations. Through guidance, education, and empowerment, we can help them take meaningful steps forward, fostering growth, healing, and transformation. So please save the date. We do have some upcoming webinar series. So there is one scheduled for May 14th. It's tracking and documenting safe use of opioids and a quality measure. And then there's one on August 13th, which is benzodiazepine and opiates and prescription monitoring. And there's some additional resources here. I won't go over them. I think they were provided for you, but there are especially the clinical practice guidelines that I did reference quite often throughout the webinar. There's some more resources here. And I do want to thank everyone for joining and participating in this webinar. This slide deck was primarily developed based on information offered by the CDC. Many thanks to Rocio Torres, the Program Management Assistant at the University of Arizona Center for Rural Health, for synthesizing the material, creating and providing additional resources in this slide deck. So I'm going to go ahead and stop sharing. And if anyone has any additional questions, any comments or thoughts that come to your mind, I'm happy to answer them. Thank you.
Dr. Coffee, would we be able to share your acronym, your PACE acronym? We'll give you full credit for it, but I think it's a really nice way to think about discharge planning.
Yes, you sure can. And I forgot, and you just reminded me, Bridget, I am a researcher and I want to use this platform, especially with the rural community, to share a flyer. I am currently conducting a cross-sectional survey that really is going to look at the barriers and facilitators and attitudes of nurse practitioners and advanced practice registered nurses who treat adults with opioid use disorder. And I'm hoping that that guides some interventions, especially for primary care. So I'm going to go ahead and share the flyer, and please share it broadly if you know any nurse practitioners that would like to fill out the survey. It's anonymous, so all responses are anonymous, and there's a $10 gift card as appreciation for filling out the survey. So let me go ahead and put that in the chat there. There you go. And then this is also a helpful recruitment letter, just in case you want something more formal that you can share. My goal is to have interventions, especially for rural community in the future for primary care. So this is such a wonderful platform to share this information. Let me go ahead and, oh, I think I direct messaged Rocio. I'm sorry, Rocio. Here you go. Sorry, let me add the flyer. There you go.
Can I make a comment?
Oh, yes, of course.
When I'm having these discussions with around opioids or prescriptions of pain medicine in my rural market and my CAH partners, they're definitely concerned and they have lots of questions around this use. If there's an opportunity, I would love to schedule some time where we could go over some of this, or maybe talk about some of their angst with you as the presenter. And I don't know if that can be set up, but just thought I'd throw it out there.
Sure, I'm happy to. I'm going to put my email in the chat here, and you are more than willing to email me, and I can discuss some approaches or even some solutions maybe, or feedback that I can give you to be a helpful resource for you. So here's my email address, and I'm happy to help.
Perfect. Thank you so much.
Thank you, Andy.
This was wonderful.
Oh, thank you. Okay.
Well, thank you everyone for joining us today. Please take the survey, the evaluation survey. We appreciate your feedback. That's how we can improve and do things different next time. by listening to your feedback. And if you have any questions or comments, please put them in the chat too, or just reach out to Dr. Coffee. And thank you everyone for joining us. We're gonna have 2 more webinars in May and August, so join us and spread the word.